Dan, anybody else coming in from out there? Yeah. Okay, I think we have mostly everybody in here now. For tomorrow, in terms of arrival and parking, so tomorrow the parking will be for free, and you enter the main entrance to the hospital. You make, I'll explain this a couple times again before we leave, but it's in the employee parking where the gates will be opened up it's called the JCP&L parking lot. So you enter into the main entrance, you make a left, and then you come down a short hill, make another left. It's right there on your right side. So you're almost heading back toward Madison Ave, but before you hit Madison Ave, you make the right, and you'll see the gates open to that parking lot. And so between 6:30 in the morning and 8 a.m., those gates should be open for you to park in there. Okay. Our next session is going to be on knee conditions. And at the end of this, the breakout session will mostly consist of teaching knee injections, and we're going to have just some cases playing in the background that you could look at and go through and ask questions about. So I'm going to introduce Dr. Wayne Colizza again, who's going to do an introduction to basic knee anatomy and causes of knee pain.
Wow, I get to talk about anatomy after lunch. I think lunch or a sedative, probably the same effect. Knee anatomy is quite honestly pretty straightforward, and I have about 10 minutes to go over it. But rather than talk about rote anatomy, I'll just review it briefly and then just speak a little bit about referral to an orthopedist for someone with knee pain. So we all know that the knee is a tricompartmental joint. There's the femur, the tibia, and then there's the patella. So we refer to three compartments in the knee: the medial compartment, the lateral compartment, medial femorotibial compartment, lateral femorotibial compartment, and patellofemoral compartment. And any patient could have any issue with anything in any of these compartments. So physical exam history is very, very important. There's some synovial spaces around the knee. Of course, the ones in front are well known. You can have the prepatellar or infrapatellar bursa. All you need to do is have a patient lay some tile in their kitchen for a weekend. They're going to be showing up in your office. What do? I aspirate them only if a gun is held to my head. I think that these things get better with time and definitely with an anti-inflammatory. And you can cause some issues with aspiration. Sometimes the knee, it has to be aspirated. It's just so large, so painful, I will drain them. But usually they go away with time and anti-inflammatory. You've got these posterior aspect of the capsule. and you can develop a Becker cyst or popliteal cyst. Those cysts can or may not communicate with the rest of the knee joint. Sometimes they actually act as a reservoir like you have in a car with a radiator. There's a separate reservoir for extra fluid when things get hot. So if you have a source of inflammation in the knee, let's say a very arthritic knee, I would not be surprised to find a large popliteal cyst. You take away the stimulus for joint fluid production, you replace the knee, the cyst goes away. Becker cysts are a dime a dozen. I aspirate them only under having a gun to my head, and I've taken 2 out in my entire career in 26 years. Early on in practice, when we thought, I think we were doing a favor to patients. The problem is these things recur. Sometimes you have to drain them and put a little cortisone in because they can be quite uncomfortable to patients. But just having the finding of a popliteal cyst, from my perspective, it's normal anatomy. And I have patients come in, and they feel a little bump in the back of their knee, and it's pretty typical of a cyst, doesn't bother them. I don't do anything for it. You, of course, have these cruciate ligaments, cruciate meaning coming from the Latin meaning cross. There's the posterior and anterior. Anterior is much more commonly ruptured in sporting activities, usually not well tolerated by a patient and gets repaired. You have the menisci, lateral meniscus and medial meniscus. These are C-shaped rings. They act as shock absorbers between the two bones. They provide stability, particularly the medial meniscus, so a medial meniscal tear can result or contribute to the instability that an ACL tear might give you. You have the quadriceps, foreign muscles, of course, form the quadriceps tendon and the patellar tendon. These things do rupture, particularly with trauma, and often need to be fixed. And then you have the articular surfaces to the bone, which, when worn out, is what we call degenerative arthritis. Or you could have a systemic illness like rheumatoid, where you have a pannus that forms and eats away, unfortunately, at the articular cartilage. Tibial plateau, this is what we talk about when we talk about the tibial plateau. By far, one of the most common areas where you'll get a tibial plateau fracture is typically on the lateral side with a valgus-type injury to the knee. Pedestrian gets hit by a car on the outside of the knee. They compress the bone together. So people with selected type of injuries, I'm always carefully looking at an x-ray to see if there's an occult lateral tibial plateau fracture. Fibular, lateral collateral ligament, medial collateral, very important structures, very often injured, the MCL. Medial collateral is rarely operated on. I think the radiologists have a stamp because almost every MRI of the knee I see, grade 1 MCL strain. So those are the basic structures of the knee that we contend with. There are examinations well described in terms of examining these ligaments in isolation to determine what's going on. There's very many tests for the ACL, the PCL, rotational tests, and reading about these tests is something that you can look up in any examination textbook, and there are videos online. Online's a great resource for education, either through the academy, or there is a website that I use a lot called ViewMedi, V-U-M-E-D-I. ViewMedi is a closed website to physicians. Don't have to be a surgeon, don't have to be an orthopedist, but you can type in something and you'll get a talk from some conference on popliteal cysts, or you'll get technological advice or surgical procedures that are on video. So it's a nice resource to go to because there's discussions attached to that video, and it's a closed website. So, causes of knee pain, like everything else, you have all of these. These go for almost every part of the body. And you have to keep all of those in mind when you're examining or taking or evaluating a patient as to the cause of their knee pain. I will mention history and physical exam are key. Dr. Lombardi referred to the hip. I always examine the hip when somebody comes in with knee pain. Very often their knee is fine, their hip is not. So always just bring the knee into bring the hip into maximum flexion and try to rotate. If they have painful, limited rotation of the hip, they have an issue in the hip, and you have to look at that as well. That could be a labral tear, could be arthritis, could be a number of things. Very typical approach is just, is this a traumatic injury to the knee or an atraumatic injury? Traumatic injuries in an otherwise healthy person with no antecedent history? Do they have mechanical symptoms? Is their knee loose? Is their Lockman anterior drawer loose? That's an ACL. Do they have swelling? I always worry about swelling after an injury. If you don't have swelling after an injury, it's unlikely you have a significant structural tear. Of course, I would never say never, but atraumatic. How long has it been going on for? Do you have constitutional or systemic systems? Do you have a deformity? Patient comes in and they say they've had knee pain for a year and a half. They have a bow-legged knee. It doesn't fully extend and doesn't flex past 100, and they have some low-grade swelling. They almost certainly have osteoarthritis. The x-ray confirms the diagnosis. If you're going to do knee x-rays, and I'm not talking about the patient who's fallen and may have a fracture, do weight-bearing x-rays, because weight-bearing really tells us what's happening to the knee joint when you're bearing weight. And osteoarthritic knees, particularly in the early setting where there isn't other findings, sometimes the x-ray taken out of hospital shows that they have a medial joint space. You do a standing film and that joint space is lost. So weight-bearing films are very important. I always do 3 views minimum. I want an AP view, AP weight-bearing. Lateral does not need to be weight-bearing, can be. And do a skyline view of the patella. We sometimes call that a merchant view, sunrise view. But I want to see what's happening in the patellofemoral joint. So always order your x-rays, 3 views, okay? MRI, it's not always my immediate next step. It's quite limited by insurance. The need is directed by x-ray, and MRI is of limited value in advanced arthritis. So if I see a patient and I do an x-ray and they have bone-on-bone arthritis, they'll ask me, well, should I get an MRI? The answer is no. It's not going to tell us anything we don't know already. I don't really care whether or not they have a degenerative meniscal tear. They are going to have one if they have significant medial compartment narrowing or lateral. The meniscus will not be normal. I'm not going to chase that meniscus. The role of arthroscopy for a degenerative meniscal tear in the context of advanced arthritis has poor outcomes. The outcomes are actually equal to about the same benefit a gel injection would give them, or in the short term, a cortisone injection. So in an arthritic wear in the knee, I just don't do MRIs. Let's say you have a patient with arthritic wear on as part of your evaluation, and they ultimately get, you come to the diagnosis of arthritis and you want to refer them on. Do you know that Blue Cross Blue Shield will not allow knee surgery, knee replacement, or arthroscopy unless they've done physical therapy first? In fact, unless you have a significant trauma, they will not allow an MRI in a simple knee pain. They'll want a history of trauma or a failure of therapy before they'll ever allow a surgery. So if you have a patient who's not horribly uncomfortable and you want to do the workup, do the x-rays. They don't have arthritis, try a course of therapy. If that fails, then send them for an MRI. Then it'll be approved, and then you'll select out those patients who need referral. If your patient has arthritis, they will not allow a knee replacement until therapy is done. So try the non-operative measures first. Try the gels, try the cortisone, try the medications. I will reiterate what I said in my breakout session. If I inject a hip, a knee, or a shoulder with arthritis, we cannot do a knee replacement, hip replacement, or shoulder replacement for 4 to 6 months, because papers are coming out more and more over the last few years showing that if you do a cortisone injection in the joint, the risk of infection goes up if you do a joint replacement. So we have to wait 4 to 6 months. So if you have a patient with really bad arthritis and suffering and you think they're going to need a joint replacement, in an effort to help them, don't order a cortisone injection. Send them to us. Let us have the discussion with them, because they may say, I don't care. I'm not having a joint replacement, and we'll try a cortisone injection. We live in one of the most endemic geographic regions for Lyme disease in the nation. Somebody comes in, no history of trauma, and they have a swollen knee, they're getting a Lyme test in my practice. I will tell you, there was one December, about 8 years ago, I diagnosed 12 cases of Lyme in our Sussex County office. So always keep that on your mind when you see an atraumatic swollen knee, with or without trauma, keep Lyme disease in your head. And when to refer, unsure of a diagnosis. Look, if it's long-standing systemic manifestations or whatever, rheumatology is the way to go. Failure of non-operative management. You've done everything we discussed for degenerative joint disease and you need something done surgically, please send them. Positive MRI with consistent history and exam. Much stronger indication for operative intervention. For example, an acute flipped meniscal fragment or a bucket handle tear. I don't operate on degenerative meniscal tears. Every meniscal tear does not get surgery. Sometimes it's hard to convince patients of that. But the success in those circumstances, particularly in the context of more advanced knee arthritis, they'll have the same benefit with a gel injection. Of course, if you see a fracture or a tumor, refer them immediately. Thank you. Any questions? Yeah. Okay. I did a paper in Journal of Rehabilitation Medicine 2015 looking at biologics versus surgery in the advanced knee patient. Biologics, unfortunately, I think, my opinion only, the people who would benefit best from biologic don't know they need it. In other words, they come to us and it's too late. There are more and more papers coming out with biologics on the treatment of knee arthritis. They're not very favorable. I think that stem cells and certainly PRP doesn't really have strong benefit in the treatment of arthritis. Where PRP in the orthopedic literature seems to make a difference are in tendinopathies, particularly lateral epicondylitis, Achilles tendinitis, where there's a soft tissue bone interface component. I think biologics have a role there because PRP brings a lot of healing factors, of course. But in terms of knee and hip arthritis, I'm not recommending PRP or stem cells for my patients. Show me more literature and I might. It's also very expensive, $5,000 for a stem cell, maybe $1,200 for PRP, not covered by any insurance or Medicare. Yeah. Well, there's a couple of ways. I send them for the usual lab tests, but you can also do a PCR for Lyme on the joint fluid. So I'll do that, yeah, as well as checking for crystals, because this could be a gout, that sort of thing.